Just bear with me. Can you get the? No, get the pump. So, just take it off. Yeah. Yeah. Yep. Sorry. How do you get it up and down? What's not happening? Yeah. Oh yeah. Can you get it back? Thank you. Okay. Good. Right. So the learning objectives are to explain the concept of treatment intent and discuss with examples. To discuss the concept of oligometastatic disease and assessing response to treatment. The first half of the talk, I'll just take you through a few terminologies with examples, and the second half of the talk, we'll make it a little more interactive with a few examples. So, radical or curative treatment. Treatment given to remove the cancer permanently. You can offer the patient surgery, radiotherapy, or chemoradiation. That is a combination of chemotherapy and radiotherapy together. Surgery can be given for patients with endometrial cancer, melanoma, early stage breast cancer. Again, the extent of surgery varies according to the stage of the disease and the type of tumor. Radiotherapy is curative for early stage cervical cancer, for lung cancer, for prostate cancers, and for lymphomas. Chemotherapy is curative treatment for chemosensitive tumors like germ cell tumors or lymphomas. And chemoradiation is a treatment where you give chemotherapy along with radiotherapy to treat locally advanced head and neck cancers or cervical cancers. The main treatment here is radiotherapy, but chemotherapy just potentiates the effect of radiotherapy to make the treatment more effective. So what is neoadjuvant treatment? Neo means before a definitive treatment or before radical treatment. So say for example, if you've got a locally advanced breast cancer and you want to offer the patient breast conserving surgery, you'd like to shrink the cancer down so that you can subsequently do breast conserving surgery, so you can give them chemotherapy or hormone treatment to shrink the tumor, and this is called neoadjuvant treatment. Adjuvant treatment, any treatment which is given after definitive treatment is called adjuvant treatment, and this treatment is primarily delivered to reduce the risk of recurrence. So I use the word reduce. You never eliminate the risk of recurrence. So say, for example, you can offer chemotherapy after surgery for early stage breast cancer, for node-positive breast cancer, for patients with a node-positive colorectal cancer who've had primary surgery, you can offer them adjuvant chemotherapy. You can offer radiotherapy to patients who've had breast-conserving surgery, because you know that after breast-conserving surgery, you have to follow it up with radiotherapy to reduce the risk of recurrence. And radiotherapy reduces the risk of recurrence by about 2/3. So it's quite important that these patients have radiotherapy. Patients with resected gliomas where complete resection is not possible, you may have to follow it up with adjuvant radiotherapy. Now, what is targeted therapy? Targeted therapy is treatment given to inhibit the growth of cancer cells specifically. And you can use targeted treatment in the form of hormone treatment or treatment like for HER2 positive disease, you can use something like trastuzumab. So tamoxifen is used as adjuvant treatment in the management of hormone receptor positive breast cancer after breast conserving surgery. Similarly, for HER2 positive breast cancer after surgery, which is definitive treatment, you can offer it with chemotherapy. Concurrent treatment is where you use a combination of chemotherapy and radiotherapy together. And chemotherapy is used as a sensitizer to potentiate the effect of radiotherapy. So here you're talking about a spatial combination effect, where if you had two modalities given separately, it would be less effective than giving both together. And this is commonly used in the management of locally advanced head and neck cancers and cervical cancers. So what is palliative treatment? Any treatment given to alleviate symptoms caused by the cancer, to prolong life but not to cure. So patients with metastatic breast cancer, lung cancer, colorectal cancer, prostate cancer, you can offer them palliative chemotherapy. Radiotherapy is offered to patients with painful bone mets due to metastatic disease, or given to patients with spinal cord compression to prevent worsening of neurology, or to patients with brain mets from breast cancer or colorectal cancer or lung cancer to reduce the local effects of the brain mets. And can also be given as a hemostatic. So some patients with lung cancer, with proximal lung cancer, which is bled into a big vessel, you can give a high dose of palliative radiotherapy to reduce the risk of hemoptysis. Targeted treatment is again used to treat patients with renal cell carcinomas. You can use tyrosine kinase inhibitors. To treat patients with HER2-positive breast cancer, you can use trastuzumab or pertuzumab, or in combination. So there are various targeted treatment options which can be used in the palliative setting. And surgery or any surgical intervention is also used in the palliative setting. Say, for example, if you have somebody with stage 4 ovarian cancer who's got significant amount of peritoneal disease and has got bowel obstruction, you can offer them a defunctioning colostomy. Or you can offer them stent insertions. If the patient is not fit for surgery and there's a single site of obstruction, you can potentially offer them a stent. Now, induction and maintenance. So before that, I'd like to say what is remission. Remission is when there is no sign or symptom of disease. And terminology like induction and maintenance is specifically used mainly in the management of leukemias, where when you say you're going to induce remission, that means chemotherapy given to induce remission, that is to eliminate the cancer. Consolidation or maintenance is where you give lower doses of chemotherapy to maintain or prolong remission. Usually specifically used, this terminology is used in acute myeloid leukemia. What is best supportive care? So any treatment given to alleviate the symptoms of cancer without treating the cancer. So example, there's no anti-cancer directed treatment. So you say, for example, if somebody's got pain, you give analgesics. Somebody's got anorexia or fatigue, you can give steroids to help with their symptoms. Patients with advanced lung cancer, you can offer them opioids to help, on oxygen to help with their breathlessness. And patients, say, for example, with esophageal cancer who've got difficulty swallowing and they have a stent, you are improving their symptoms without necessarily treating the cancer. So coming to survival and prognosis. So I've just tried to make these, introduce this concept very simply without, defining them. So overall survival. So how long a patient has been alive following the diagnosis and initiation of treatment. That is time from diagnosis or treatment to time to death. So how long have these patients been alive is overall survival. Disease-free survival is how long has a patient been free of disease before the cancer relapses. Okay? And progression-free survival is how long has the cancer been controlled before the disease progresses again. And these terminologies are quite important to assess the effectiveness of any treatments, and especially used in clinical trials when they want to compare treatment A with treatment B. If you say that with treatment A, there was a 50% 5-year survival, and with treatment B, there was a 75% 5-year survival, that means that treatment B is more effective than treatment A. Now, prognosis is the estimation of outcome of a disease or the course of a disease. So it's like when the patient comes to you in clinic and asks you, so doctor, what are my chances? So you can say that, patients like yourself, it depends on the stage of the cancer, the histology, and the molecular profiling of the cancer as to how long you're going to survive. So, and survival is like is a tool used to prognosticate patients. Okay. So, oligometastatic disease. Now, oligo by definition means few. Metastasis means where the cancer has spread from the primary site to other parts of the body. And this is a concept which has been introduced in the last 15 years or so, because previously the concept was, if you have localized disease, you're likely to be cured. If you've got metastatic disease, cure is not possible. But oligometastatic disease is an intermediary state where the cancer exists with limited sites of metastasis before the cells acquire ability to develop widespread metastasis. So for example, and for these sort of patients where you have oligometastatic disease, local treatments can be potentially curative. But the key is to be able to identify these subset of patients who can be treated radically and you can potentially cure. So by definition, oligometastatic disease is when you have 1 to 5 metastases not involving more than 2 organs. So that's a general rule of thumb. And truly, oligometastatic state includes a long latent interval between the diagnosis and treatment of the primary tumor and the appearance of metastasis. That means you've got enough time to assess the natural history of the disease. So what are the treatment options for oligometastatic disease? So you can offer them surgery, radiotherapy, or radiofrequency ablation. And so I'm just going to focus on surgery and radiotherapy. Say, for example, if you have somebody with a colorectal cancer and you've done a staging CT scan and you find 2 lesions in the liver, these patients can potentially be cured by initially giving them chemotherapy, and then you can have surgery for the primary tumor as well as resection of the 2 liver lesions. Similarly, if you have somebody with, like, say, an osteosarcoma of the bone, a young patient has been treated many years ago, and then on follow-up, X-ray shows up or scan shows up 2 lung metastases, you can potentially offer them surgery with the view to cure them.